And when you do this, all this trial you summarize, then what you have? You have, if you have a heart criteria like Mohit said, you dialyze. If you don't have a heart criteria, then we all now we should agree that we wait. We wait for either the heart criteria to appear or the patient is either 48 or 72 hours anemic and you start dialysis. So because we did that and informed that, a lot of patients didn't have the CABSA, a lot of patients didn't have the non-renal recovery, didn't go to CKD. So I think this is the best way to deal with. But then if you see the AKI-2 trial, delayed and how delayed. So when they delayed it by say we went to 140, further delay, the result is not so good because there's a trend of having more harm in there.
There is one up to certain level, 140,
112 is good, 140 you go there, then you have a lot of GI complications, GI hemorrhage and all that. But the point is that in the delay, it's not that you are delaying it from
you have raised that question. I'm going to ask that this delay is going to do harm to my patient because we are pushing hard to that patient to the certain level.
It didn't, but you said that you only do 5 to 7% patient into the dialysis and less patient didn't have dialysis. Nothing harm happened to this patient, and long-term renal recovery is fantastic in those patients. Then patients didn't have the side effects of CRBSA and all and this catheter-induced trauma. So I guess delay is good, but at some point of time, and you have to really monitor those patients. So this is very important in the delay.
These are all about, there was no harm. There was no harm for the simple reason because all these studies looked at all-cause mortality. It was not the cause-specific mortality because naturally question for us would have been that there should be harm. Why there was no harm? Both in the early and the late phase. So whatever benefit was obtained by this technique that got lost because of the other causes of mortality. So unless and until we specify the disease-specific causes of mortality, we won't be able to reach that.
Yeah, that's a heterogeneous group, and most of the patients are heterogeneous group, and that I agree. But the science has to go forward, and we have been talking this RD for last 10 years, if not more, and only one study has shown there is benefit. That was only cardiac. Those all patients are post-cardiac surgery and a single center. I think I'm alien study. But rest is all in favor of delay. But still, there is a question that how long we should delay our patients. So because many patients are, even we are treating them with the renal replacement therapy is not coming out of this crisis.
This has to be individualized. So
that's the question.
Because starting AKI was good because there was a physician discussion of starting the dialysis. So I think that is the best part of it.
And question to do you think that anything related to cause or pathophysiology is going to tell us about the response to RRT? The patient who has got pre-renal, the patient who has got renal, or patient who has got post-renal, or patient who has got contrast-induced or drug-induced, anything going into the stage 3, not the early stage. And then you are putting them on RRT. So is there any difference in response to treatment?
Of course, I think the patient who are very hardly suffer, very is the imperial syndrome. And the patient is diagnosed, they have common along with renal dysfunction. So I think the pathophysiology and pathophysiology also doing like HRS, the mechanism is a little bit different and that not respond to any kind of. So in these cases, I think response to treatment is very poor. But in the patient who have like AKI with cardiac surgery, the patient is drug-induced AKI or acute renal failure because acute liver failure and AKI with the viral hepatitis or diagnosed. These patients with the pathophysiology like ATM, they will respond much better to the treatment and the respond to the dialysis.
Next second question should be to nephrologists that we have got different types of renal replacement therapy, different types and there are merits and demerits, and a particular group of patients you have to have these facilities. Just within very short time you can highlight because this is
okay, so we have intermittent hemodialysis, we have PART or SLET, and we have CRT. So all summarized is that whoever is comfortable with what. So I guess if the people are very comfortable with CRT, which we are not in India, so it's better to go for SLADE or part if the patient is hemodynamic unstable, having 2 inotropes and maintaining the blood pressure of say 170 MAP or say 72. It's ideal for SLADE because we are not well equipped, not a lot of technicians will be doing the CRT. So if we start CRT over there, probably we will be losing the patient, the system plotting and all that. Now, if a center like Australia and New Zealand, they will be doing the CRT because they are well versed. Everybody knew how to do the CRT.
Is there an added advantage of CRT?
See, this hemodynamic unstable patient, when you put them on the CRT with a lot of lactate, obviously there is an advantage because you don't induce a lot of hypotension there. The renal recovery is good. You take a lot of cytokines removal. But then when the study was there with the CRT versus SLADE, there is no advantage in the CRT group. Even high volume ultrafiltration, no added advantage over there. But then it's a belief that you start the CRT
Except in two group of patients. One is
oh yeah, right, okay. So you have the hepatorenal syndrome patient, the pediatric age group patient with intracranial pathology. So these are the patients that strictly indicated. Strictly indicated the CRT pediatric and the hepatorenal group and this patient with IC hypertension. So these are the group. Otherwise, I think in our setup in Southeast Asia, it will be better to go for SLADE. Even if you have a little, 110 by 70 it will be SLADE, but if you have a 140 by 80, it will be intermittent hemodialysis, will be as good as SLADE. So
I think all of the panel members agree with. I do feel that SLADE is very good, and if you want to keep them prolonged, you again start them because the machine is designed for 8 hours. Then again you start. So it comes like CRT sort
so
of.
it's only the port. The port has to be there. So now we have ports everywhere. That is one thing. And when I was DNB teacher in R&D, we shot up a small series of patients, CRT versus SLADE in that patient, and obviously SLADE was superior to CRT in the critical care because of this issue, the technical issue. These technicians and sisters are not well versed with the CRT machine.
Just one more question, because we do see AKI in CKD in our unit, because this is another group. AKI, but they are totally different. So, do you think that they should have the same kind of treatment like what we have been doing for just main patient with AKI?
I guess so because AKI and CKD and pure AKI, there is no hard criteria that you start dialysis in the ACKD group early. Only thing is the acidosis will be high in the ACKD group because they are already having some metabolic disorder in the CKD, already acidotic, and then they insert sepsis or whatever, so they have a lot of acidosis. Maybe on that regard you have to start the dialysis little early in the ACKD group, but otherwise, if you go into the trial again, so you see all those trials in the early and middle group, same amount of patients, the percentage of patients of CKD is the same, and the outcome remains same. So it's not that you have to be really energetic about CKD patients going into AKD and start the dialysis earlier. It's again, individualized. You have to create need, and the patient has a gastroenteritis or whatever volume loss kind of AKI, and then you give volume and treat the same way as you have treated the patient with one creatinine. Mike, what do you say?
Yeah, fully.
When I around starts medicine, AKI, CKD is always respectful for the AKI. Always, so there's a patients who consider high risk group. Management we can't change in anyone whatever the AKI. But important things that we should try to begin any new insert on these patients. Because any insert will be further progress, lead to progression of that underlying renal disease. And these patients, with the various trials shown, these patients have high chance of developing insert even developing AKI. So we should be precautious and we should avoid any other insert.
No, right, you already had that insert. The patient already had that insert. You insert.
Any questions from the audience? Because I am to finish. There are a lot of things we can discuss, but I think these are the burden questions with when to start RRT in AKI.